panel sitting with us today. We've got one stand-in. Thank you very much for helping out. But what I thought would probably be the best is for each individual to introduce themselves, but in particular is to say how and where they're using robotics to enhance healthcare delivery and clinical outcomes in their particular setting, because I think the background is quite different. So.
Yeah, thanks, Judy. My name is Raymond Bila. I'm the CEO of Herman Joseph Hospital, and we started robotics in pharmacy. I think the first public hospital to use robotics, perhaps in the whole of Africa, if I'm not mistaken. And we partnered with Right to Care, which is an NGO that works with in the AIDS HIV field. And when we started with robotics in pharmacy, it was because there were challenges with waiting times for patients to get medication, problems with adherence. And so they came up with an idea that if we look at automating or dispensing, it could shorten the waiting times, and also we could get upscale our adherence, and also get more information about data in terms of patient medication that we dispense, and also manage our stock in the pharmacy. So this was started about 2012, so, but I think it was upscaled in 2013. And the Minister of Health came to the hospital in 2013 and was blown over by what was happening, because I think a few years back, he was there, and because of the numbers that we have, because of the problems with HIV/AIDS in the country. There was quite a huge number of patients, more than 10,000 to 12,000 that we had. And because we're a tertiary hospital, and we were the first to start treating patients with antiretrovirals many years ago. So the numbers were quite high. And so when it came the first time, the volumes were quite high, waiting times were quite long. And when he came back a few years later, and he was astonished to find that the waiting times had actually decreased. We also started down referring patients. And the idea was then to develop that perhaps we should then start this system of getting robotics in the pharmacy in the whole of the hospital, because at that time it was only for a clinic, which we receive about 300 patients, currently about 300 patients per day or per clinic. But now the challenge was to say, roll it out to the main hospital. But the idea was to roll it out at bigger hospitals like Crystal Hospital or Steve Biko. And I was jealous. I said, we are the pioneers, so let's start it here. So we started robotics last year in August. Steve Biko was the first pilot site, so there are 2 pilot sites. I think we can talk about what has been the challenge. But I think the development of that was also to start using an ATM type of dispensing, where patients can just go in and use a card like you go to a bank and you slot it in, and then up comes your medication. So that is, we've got a pilot, but I think in Alexander Township, that is where it is being piloted also. It will be taken over to Soweto, also some clinics or the shopping malls in Jablani in Soweto.
Right, hi, I'm James Ari. I'm a specialist urologist based at Waterfall Hospital. Recently returned from a fellowship in robotic surgery in the UK. Obviously, I used the Da Vinci robot, which Aki was talking about, and I hope he was using it as an experiment, not under the knife on the Da Vinci robot. Maybe just to fill you in, one of the subheadings we could talk about was success stories in robotic surgery, and we use the robot not to replace healthcare practitioners yet, but to augment our skill and our ability. In South Africa, the first robotic procedure was done on 25th November 2013. There are 5 Da Vinci systems in South Africa and 1 in Egypt. They're in Urology Hospital in Pretoria, Netcare Waterfall Hospital in Johannesburg, Netcare Christian Barnes Hospital in Cape Town, Green Acres in PE, and Durbanville Medical in Cape Town. So far, 2,312 robotic surgeries have been performed in South Africa, mostly for urological indications, but for other indications as well. So I'm a very small cog in a very big system of robotic surgery, which is already successful in South Africa.
Hi guys. My name is Elliot Sack. I'm representing eHealth Group. I'm actually the founder and CEO. We got involved in exploring robotics when we identified the lack of specialists and medical resources in Africa. We reached out to a company called In Touch Health, who they use the same network as Intuitive Surgical, which is a Da Vinci robot. So we have our own cloud-based telehealth network, which enables specialists to connect anytime from anywhere in the world on a low connectivity platform on a 99.2% connection rate. And it connects through robotics. So we have different types of medical devices, from pre-hospital type handheld mobile devices that go into ambulances and helicopters to Class 2A FDA cleared medical robots that have autonomous capabilities that can navigate through a hospital. It has memory, so it can memorize hospital wards and can navigate and go directly to the patient's bed with the touch of a button on an iPad or on the phone or on your computer. And then we have push cart type medical devices that enable the doctors to provide high acuity care, and also we obviously have solutions that go into the primary care space, which would be lower acuity devices that just enable the consult. So the robotic technology that we utilize is just the endpoint to enable the doctor to be into the facility. Really, the doctor, the specialist on the other end, controls the outcomes of the patient hand in hand with the clinician on the other end. So whether it's a nurse or a junior doctor, so a lot of the doctors in the rural areas don't have certain expertise, they don't have access to these type of specialists, whereas they do in the metropolitan areas and the major hubs like in Johannesburg and Cape Town. And our plan is to utilize our specialist resources that we have in say, Johannesburg, and leverage off of them across the entire country, especially into the provinces like the Eastern Cape, Northern Cape, Northwest, where they don't have access to these specialist services. And the robots, there's a lot of interoperability. It enables integration of other medical devices like ultrasounds, ECGs, otoscopes, different types of cams, and also integration with your medical records and your PACS. And literally it virtually puts a doctor anywhere at any time with the convenience and the reliability and the secure connectivity to provide high acuity telemedicine.
Good morning. My name is Dr. Andrew Sewanywa. I come from Dr. George Mukari Academic Hospital, and I'm here on behalf of our CEO. He wasn't able to make it, but I'm one of the clinical executives at the hospital. Our hospital is one of the 4 central hospitals in Gauteng province, and we come from the rural areas of Pretoria. Our mandate is mainly to provide healthcare services as well as training and research. And our perspective of approach to robotics is really on the receiving side. We've had presentations in our hospital as to what robotic technology can do. But in the technological side, we render services. I think our hospital is one of the leading centers in minimal invasive surgery, and we've introduced technologies such as the PET CT scan, and in addition to the standard CT scans which we are using in the hospital. And so our interest is in that we serve a huge community, a huge rural community, and our hospital renders outreach to areas as far as Northwest and Limpopo province. And we get a lot of referrals from primary-based hospitals and regional hospitals. So one of our areas of interest is to try and minimize unnecessary referrals, because there are quite large distances between us providing a service and the hospitals that refer to us. So we are interested in having access to this kind of robotic technology, which would probably help us to expand our outreach and to empower the communities that we serve and the healthcare providers in those areas. So we are quite keen to get on board with the new technologies and remote robotic technology in terms of service delivery and healthcare, because we think it will also go a long way in minimizing many of the complications that occur because of delayed access to tertiary healthcare and the scarcity of scarce skills availability to reach out to some of these rural areas. So we're looking at robotics as one of those areas that maybe we could exploit to help us expand our outreach.
I think, a burning question I have is, when you think of robotics, you think, geez, this is going to be expensive. And especially when you look at the size of your dispensing units, it's quite a piece of equipment to put into a facility. So perhaps two questions into one is, how do we overcome that perceived expense of robotics? So where is it giving us better outcomes, probably a better kind of a lifetime cost benefit? But also, I think to your point is, with that kind of expense label, where do we see those outcomes and how do we potentially integrate that better into the public healthcare system? I don't know who wants to.
Maybe I can start there, Julie. For sure, robotic surgery is expensive. I think Da Vinci robot's about 28 million rand at the moment. And it's quite hard to do a cost-benefit analysis because you really only appreciate the benefits over a very long term. But even if you look at the short-term benefits, the patients go home. Sometimes in the UK, they're sending patients home on the same day of radical prostate cancer surgery. And we've heard already about costs of admitting patients to hospitals, to central hospitals overnight, running into thousands. So although it's a big capital outlay at the outset, I think there are definitely cost benefits down the line in terms of the patient's outcomes and direct cost benefits to the hospital. So I just don't have the exact figures to weigh those two up at the moment.
Yeah, I could elaborate. So there's obviously a capital expenditure and OpEx expenditure of utilizing robotic technology, but the financial savings far dwarf the actual expenditure of the technology. If you look at what it would cost to put a specialist into another hospital where we don't even have those type of specialists, it's the level of salary wages are, the amount of a salary for 1 year specialist could pay for multiple robots. There's different models. So people think automatically they hear robotic and they think expensive. You could there's leasing options. When you look at it on a monthly payment, you could lease a robot for around 25,000 Rand a month, 40,000 Rand a month, and put 5 robots into 5 different locations and have an intensivist, a specialized intensivist sitting in a tertiary academic institution providing care to multiple locations, real time, upskilling your junior doctors, reducing medical legal, because now you have expertise in areas where you're having nurses making decisions. A lot of these consultations are over phone. So what's currently occurring is that you're having a nurse or a GP, a junior doctor, calling up a specialist in the middle of the night saying, I'm having a patient that's bleeding out, what do I do? And they don't explain to the doctor. So over the phone, it's insufficient way for a doctor. Now doctors are making decisions without the right information. They're not able to see the patient. With robotics, you can see the patient, you could see the vitals, you could see the CAT scans, the MRIs, you could see whatever type of information that you would want to help make a more guided decision, which will in turn, for instance, in stroke, save a lot of money. Stroke patients, when a lifetime care cost to a patient in state, I'm not sure the exact figures, but if you look at what a lifetime patient for stroke in private sector, it's in the millions of rands. A robot saving one patient from lifetime debilities from stroke would pay for one robot. So literally, the technology can fund itself. And that's what we're going to look at doing is, especially in public sectors, because we understand resources are low. So we're going to look at building programs and proving concept in ways that we can save money for the governments and provincial, national departments of health by leveraging off of these resources, reducing unnecessary transport. So transporting patients from rural areas into the main academic institutions, it costs a lot of money. Plus, it takes a long time for the patients to get there, so there's a lot of mortality. We need to reduce the mortality in pediatrics. There's the massive scarcity of medical, we only have a couple centers of excellence of pediatrics in the country, Mandela Children's, we also have Red Cross Children's, but that expertise is in Western Cape and now in Johannesburg. What about the other provinces? And then what also the robotics enables is that doctors in private sector can also work in public and private. So they could create partnerships between specialists that work in private facilities to also provide care, because government resources scarce and doctors all want to work in private, but now they could also consult to public sector while sitting at their practice in Netcare Waterfall. So I think looking at unlocking the savings of utilizing robotics and what the clinical savings are and the clinical outcomes, and if you look at it on a long-term scale, and then you weigh it off of the investment of the technology, and we could showcase that that's going to far outweigh it. Maybe I'll pass it to Dr. Billa.
Well, I think for me, at this stage, it's a bit too early to say there are any savings that you derive from the robotics. I think the capital outlay still, we said we lack funds in the public service. And we had earlier on the NEC speak about that the biggest problem is funding. Because at this stage, we didn't have to spend money to get the equipment. We depended on donor funding with our partners. But going forward, we're not certain exactly if we're going to realize those benefits in terms of cost. But what we can say is that when you look at the ATM type of machine that we want to install, that at least it saves time. Patients don't have to clog the system, don't have to come in large numbers to the hospital. Patients on chronic medication can come at any time. After hours, because some of our patients come in the mornings. At one time, I doing my rounds in the hospital, 3 a.m. patients are waiting to get into the hospital. I said, you don't have to come at this time. So they don't have to come. They can come at their own time. But also we reduce the number of high-level pharmacists that you need to employ, because then you reduce the time the pharmacist spends in picking up the medication and dispensing, because the machine itself picks the medication from the bag. At the same time, whilst the pharmacist is dispensing the medication, it begins to sort out the medication and put them in the right places, storage facilities. They are included in the packaging. And you need only to have the backup staff to load the machine. So you get the low-level staff, the pharmacy assistants. So you may realize some savings in terms of employing senior, high-level staff like the qualified pharmacists, because we have fewer pharmacists in the front, and they have more time to spend with the patient. So I think that's the time that you save with the robotics that we think that we have at the moment.
I mean, you bring patients into this, and I think there's almost two extremes of it. You've got one set of kind of technologically advanced that kind of think, oh, this is a great idea, and on the other side, you get a lot of cynical patients and say, well, hold on, a machine is going to take over my care potentially. I mean, I'm thinking, especially in the middle two. I mean, yours is more of a dispensing; it's a saving in my time. I mean, how do we deal with it? How do we deal with reducing the skepticism around having technology taking over part of a role that a clinician would have previously done? And what's the overall kind of user experience that we need to bring into that?
I can just very briefly, sorry, Dr.
No, you can.
And certainly from a surgical point of view, as I said at the beginning, the robot is just an augmentation of the surgeon's ability. It's not a replacement for the surgeon. So in my experience, our patients have all been quite excited to be operated on with a robot, not by a robot. And we certainly haven't experienced those challenges. But I think maybe when the patient is presented at the point of care with a robot rather than a person, that's maybe when you experience those problems. So maybe Raymond can just comment on that. Yeah. Sorry, Eddie, sorry.
I'll comment, yeah. So look, there's been many studies. So just to touch upon the last topic quickly, there is actual savings. Our systems installed over 2,000 hospitals globally, and the top healthcare systems are showing millions of dollars in savings, in the billions in telemedicine and telehealth. But we'll get to that. As far as patient experience, so especially in pediatrics, the children love new technology. So we don't feel like there's going to be any backlash from the children. I think children are embracing the technology globally in all the pediatric centers of excellence around the world. I think with you're going to have some skepticism, but if you think about it, in a situation when you're having an emergency and you need to see that specialist right away, when you're in a trauma situation, a heart attack, a stroke, and you know that you're going to have an emergency physician, emergency senior doctor assisting a GP, you know that you could get a second opinion. I think that a lot of patients are going to open up. There's been a lot of studies by the PwC, KPMG that are showcasing that telemedicine services are roaring and they're growing rapidly around the world. So I think that patients are really wanting to know that they want to get access to specialist services, because what they're currently doing is just going to the hospital where the specialists are. So now they could go to their community hospital and get access to the specialist. Granted, it's through a robot, but yet they're still getting to see that specialist rather than traveling long distances to see that doctor. And I think that inconvenience of traveling, time lost, missing of work, kids miss school, it's costly. So, like for instance, I know someone that had a clinical issue recently, and we went to a main hospital. We went to Mill Park Medcare. The waiting line in the ED, there's a lot of waiting time. So think about it. If you could, for instance, I'll put it in your port. If you could skip a line and see a specialist right away rather than wait in a busy ED, would you not do it if it's through technology? Or are you going to wait an hour to 2-3 hours for that doctor, or till the next day? So I mean, waiting, it's convenient.
Yeah, I think patient experience is important, and also user experience. I'll talk about two issues. I think when we started robotics at the hospital, we started quite passionate about it, and they were excited to get the machine going. But after some time, because you have challenges with software problems, and I think someone spoke earlier on about user experience, and the machine began not to function as expected. Okay, that begins to demotivate the staff, and I think that's where we are at the moment. Because when we compare our waiting times, in a smaller clinic, it seems to be working quite well. Because with our HIV/AIDS clinic, the waiting time is about, we support 30 patients, 300 patients per day, and we've got fewer waiting times. And we come to the main hospital now, where we see close to 6 per day, 600 to 850 patients, just patients that we go to dispense, and close to 3,000, right? 5 items per patient. It's about, multiply that by 800. That's the number of scripts that you've got to dispense. It's quite a large volumes. And so I met a patient over the weekend, and she's been to another hospital. She says, "No, this robot of yours is not working. Think about, you use differences in lean method, which is much quicker way." But I think it's because it's early times, we can see the advantages of using the robot, because you now have patient data, you've got more information about what patients are using, you are able to know what stock levels you manage on a daily basis. But I think in the long term, you will be able to get more benefit out of using the machine. Then you can clean up the system, the patient flows, so that at least you get some mileage out of it. But I wanted to talk to Aki. I think you spoke about the CT scan, and if we do have that. Sometimes people don't think that in the public service we have these innovations. And we've got a sister hospital just 2 kilometers down the road, because we are a general hospital and they are a mother and child hospital. So we've got one radiologist who covers both hospitals. So we do a CT scan. We just started with our PEG system and teleradiology. So we can take images at Raima Musa and then relay them to Ellen Joseph Hospital. So the radiologist would treat the studies at the hospital. In the past, we used to go to Rahima Musa, drive down there, come back with the films and give them to them. But now we don't have to do that. We save time. Both hospitals are connected, and the idea is to connect all the cluster hospitals within Johannesburg, Charlotte Macquarie, Johannesburg, and the east and the west. So there'll be one big center that we have. So we can, all the hospitals will be interconnected. And so this is what we're currently doing. It's about 10 hospitals that will be connected together.
Yeah, I think any kind of change is always difficult to introduce or to accept, but I think the key thing is that it must be user-friendly, and the availability of this technology, I think the acceptability in the community would depend on the results that come out of its use. If people find out that they can benefit from the service more than having to travel long distances and to spend time in long queues, and there's an alternative to that, if ultimately the end result is that they get their service delivered in a more convenient way, it might take time, but with time, once the results show that it's beneficial, I think then the community would be more accepting of technology. Like if you consider the use of mobile phones, almost anyone, anywhere, even in the rural community now, are quite comfortable with the use of mobile phones. But that is a technology that has been found to be very convenient, even in other forms of communication and use of, let's say, making payments. So if a technology is proved to be convenient and effective and user-friendly, then I think that will deal with the acceptance in terms of the community accepting that kind of service. But also in terms of cost, compensation of employees is one of the cost drivers in the National Department of Health. And it is a fact that it's expensive to run a tertiary service. The training that is involved in getting the specialists to the level where they are, a lot has to be spent in that exercise of the training. But if we are able to extend the reach of the limited resources through the use of technology, then I think that will also tend to improve the aspect of the cost drivers.
Thanks a lot. I would like to open up the floor to questions, but we're trying to catch up a little bit of time going forwards. But firstly, I'd like to say thank you to the speakers, but I think as a wrap, I think it's almost a no-brainer that we need to move into the space of robotics and artificial intelligence. I think we face a massive skills shortage on the continent, and how can we use this technology to advance that? And certainly I've just come back from a conference, a Blueprint for Success, which was in Zurich last week, and there's a particular facility that we're looking to put an initiative together that's utilizing all of this type of technology, both from a mobile health, which I know we're talking about a little bit later, remote-based care, but also a little bit about using that technology to bring more specialist clinical skills to the more rural areas, so the oncologists don't need to travel, etc. But I think we've also got to be a little bit realistic in that we do need to overcome some significant challenges. I think connectivity is one of them. I think the fact that you're relying on technology and you constantly need to have that updated. I think it's also about upskilling our clinicians to be able to do it. And I think ultimately, as we get a larger rollout, is how do we use that and plug it into a much more integrated healthcare record, be it public or private. So if something happens to me, it doesn't matter where I go, that information resides. So hopefully we've caught up a little bit of time, Aki. And thank you again, panelists.
Thank you very much. Panelists, give a round of applause.